Bismillahirrahmanirrahim. Respected students, I am Dr. Muhammad Ansari, Assistant Professor of Pediatrics, and in today's lecture I am going to discuss inflammatory conditions of heart. That is myocarditis, inflammation of the myocardium, endocarditis, inflammation of the endocardium or the inner lining of the heart, pericardium, inflammation of the outer lining of the heart, and rheumatic heart disease, which is a post-inflammatory condition of the heart. Infective endocarditis is an infection of the heart chambers or valves. Most commonly affected valve is mitral valve and then followed by aortic valve. The valves on the high pressure side are more commonly affected. People who have cyanotic congenital heart disease, they are at higher risk to develop infective endocarditis. There are two types, acute infective endocarditis and subacute infective endocarditis. Subacute infective endocarditis most commonly affects mitral valve, and acute infective endocarditis most commonly affects aortic valve if when it involves only one valve. Endocarditis of the mitral valve, I have given a little more explanation in this case because it is the most commonly affected valve. So whenever there is involvement of the mitral valve, strep endocarditis resulting in large vegetation on anterior leaflet of mitral valve in this case, which results in impaired closure of the mitral valve, thus leading to regurgitation. And this regurgitation jet creates back pressure on the lungs and causes plethora and causes heart failure, causes jugular venous pressure increase, causes facial puffiness and facial hyperemia, facial plethora. So mitral valve is the most commonly affected valve, and Streptococcus viridans is the organism which most commonly causes this. Infective endocarditis leads to thromboembolic phenomena, which can affect brain, leading to stroke, leading to infective emboli causing abscess formation. There can be involvement of the retina and vision, where there will be hemorrhages in the retina. There can be thromboembolic or splinter hemorrhages involving the conjunctiva and nail. There can be Janeway lesions which can affect the palms and soles of the patient. There can be a hemorrhagic condition of the kidney. There can be hematuria. Involvement of spleen can be infective. There can be splenitis. There can be abscess formation in the spleen, or there can be thromboembolic phenomena leading to necrosis in the spleen, and spleen will be enlarged, liver will be enlarged, patient will be in heart failure, will be having very high grade fever, continuous fever, and will be listless. These slides give an overview of the clinical features. Due to infections or dislodge of vegetations into the system causing immune response inside it rely. These vegetations are basically like pustules, like follicles, like folliculitis, pus-filled pustules, which when erupt, they cause thromboembolic phenomena in different parts of the body. Cerebral emboli 15%. Roth spots in fundi. When you do the retinoscopy, ophthalmoscopy, you see Roth spots in the retina. Petechial hemorrhages on mucous membrane and fundi. They can be poor dentition. Poor dentition is a risk factor for infective endocarditis. Splenomegaly is seen in 30 to 40% of cases of infective endocarditis. Long-standing endocarditis only. If it is of acute, you might not see splenomegaly. In subacute infective endocarditis, yes, you will see splenomegaly in 30 to 40% of cases. Systemic emboli, nail fold infarct, splinter hemorrhages, digital clubbing will also be seen if there is cyanotic congenital heart disease or the child has long-standing endocarditis. Subconjunctival hemorrhages are seen in 2 to 5% of cases. Varying murmurs, 90% new or changed murmur you will see in cases of infective endocarditis. Conduction disorders of heart, meaning by you will see abnormality in the ECG, PR interval prolongation, or poor propagation of QRS complexes, or decreased amplitude of QRS complexes, or presence of Q waves, you will see in cases of infective endocarditis. Cardiac failure is seen in 40 to 50% of cases, hematuria in 60 to 70% of cases. Osler nodes are formed because of the infective emboli lodging into the distal pulp, and they are very tender to touch, whereas Haberden and Bouchard nodes, which are seen on the proximal and distal interphalangeal joints seen in osteoarthritis, they are not tender, whereas Osler nodes, they are seen in the pulp of the finger and they are very tender. Petechial rash is seen in 40 to 50% of cases and may be transient. Let's come over to the myocarditis. Most of the cases in pediatric population of myocarditis is post-infectious viral myocarditis, of which Coxsackie virus, influenza virus, parainfluenza virus, and coronavirus are the leading causes. Myocarditis causes the heart muscle to become thick and swollen, and there is poor contractility of the heart, and we will have to give immunosuppressant or strong anti-inflammatory agents so that myocardium keeps on generating cardiac output and stroke volume so that bodily needs are met. It can be managed with steroids as well as IVIG or plasmapheresis, or it can be managed with ECMO or heart-lung bypass temporarily till the time myocardium acquires the contractile function. Pericarditis is inflammation of the outer layer of the heart. Pericardium normally contains very thin rim of fluid between the myocardium and pericardium, but when there is inflammation, the pericardium is thickened, it's hyperemic, blood circulation to the pericardium is increased, and this is an extremely painful condition. Patient will be unable to lie down on the bed. Patient will keep on sitting, bending forward, so that his or her heart keeps suspending inside the pericardial sac and does not touch the chest wall or the posterior thoracic wall, and patient will acquire like tripod position, and it's a very severe condition. In cases of tuberculosis, later on it can lead to constrictive pericarditis. In cases of systemic lupus erythematosus or other autoimmune conditions, it can still lead to constrictive pericarditis and is managed by specific therapy. For example, in tuberculosis, managed with anti-tuberculous drugs along with anti-inflammatory drugs, steroids, and in cases of autoimmune conditions, managed with immunosuppression. Pericardial effusion, when there is excessive fluid accumulation between the pericardium and myocardium, this is called pericardial effusion. If this fluid is clear, exudative or transudative, or it can be blood which has come out through a perforation of myocardium. If this fluid fills under very high pressure, then it leads to cardiac tamponade. In cardiac tamponade, the heart is being pushed inwards, and the heart doesn't relax during diastole and doesn't allow cardiac return, thus unable to generate cardiac output, and this is an emergency which need to be evacuated immediately. Rheumatic fever is an acute inflammatory response to a past group A beta hemolytic streptococcal infection. Rheumatic fever occurs 3 to 4 weeks after an untreated, partially treated beta hemolytic streptococcal infection. An antigen antibody response triggers tissue damage in specific areas of the body. Rheumatic fever previously used to be a very common and lethal disease, but alhamdulillah, with the advent of investigations and use of appropriate antibiotics, within 9 days of start of a streptococcal sore throat, the episodes of rheumatic fevers are on a decline. This is the criteria, John's criteria, revised Duckett-John's criteria for rheumatic fever. The acronym is John's P's. J stands for joints, polyarthritis, hot, swollen joints. O for heart. When there is carditis, the heart takes globular shape. So this O is denoted for carditis, and there is valvular damage as well. N is for nodules, subcutaneous on extensor surface. Subcutaneous nodules on extensor surfaces, especially on the shin. E is erythema marginatum. This is a painless rash which is again seen in the lower limb most commonly, but can be seen in the upper limbs as well as in torso. S is for Sydenham chorea. This is flinching movement disorder. Minor criteria P's. Previous rheumatic fever. If somebody has previous rheumatic fever and this time again he has sign and symptoms consistent with rheumatic fever, this is one of the minor criteria. ECG with PR prolongation. Arthralgias. Arthralgias is just joint pains, whereas the major criteria arthritis, joints involvement, is hot swollen joints. C stands for CRP and ESR elevated, and E is elevated temperature, meaning by fever. The diagnosis of rheumatic heart disease is made with a history of recent streptococcal infection and either the presence of two major criteria or one major with two minor criteria. Here one thing is very important, that if in the presence of Sydenham chorea at any point, usually Sydenham chorea presents 6 to 12 months after the first episode of rheumatic carditis. If there is Sydenham chorea, this single finding is sufficient to label somebody having rheumatic fever. Repetition sometimes are important so that one remembers things. Major criteria: carditis, polyarthritis, chorea, erythema marginatum, and subcutaneous nodules. And minor criteria: arthralgia, fever, laboratory findings of raised ESR, raised TRP, prolonged PR interval, and history of previous rheumatic fever. Thank you very much, dear students.